Welcome everyone to our first Canadian Diabetes Association National Webinar Series. My name is Farah Ismail and I'm a Program Manager for the Canadian Diabetes Association, and I will be your host for today. We're delighted that you're able to join us for the webinar to learn all about the ABCDs of a healthy lifestyle. Now, to start off, I would like to draw your attention to the survey at the top right-hand section of your screen. In order to better serve your needs, we kindly ask that you provide us with your input by completing the short survey towards the end of the presentation, and we do thank you in advance for your input. Throughout the presentation, we will have the opportunity to type in the Q&A box at the bottom right of your screen. We ask that you use this box for any questions you may have along the way, and our presenter, Dr. Peter Lynn, will be happy to answer them at the end of the presentation. As well, we will be displaying a few polling questions throughout the presentation. We would love for your participation in the questions to help us gauge who our audience members are. Please note your answers are completely anonymous. Also note that you are able to customize your screen to expand or collapse the screens that you see, so do feel free to adjust them as needed by dragging down the bottom right-hand corner. The presentation itself will last about 40 to 45 minutes in length, and then we'll go to a Q&A for about 15 minutes at the end for questions. It's important to note that we will be recording the sessions and posting it on our CDA website at a later date. So now I'd like to welcome you to our speaker, Dr. Peter Lynn, and thank him for joining us today. Before I turn it over to Dr. Lynn, I would like to give you a brief bio on him. Dr. Peter Lynn is the Director of Primary Care Initiatives at the Canadian Heart Research Centre, and he's given over 120 lectures in 2013 alone. He has 2 busy family practices in Toronto, and currently he is the health columnist for CBC Radio. He has also been a guest editor for Focus on Cardiology and a consultant for Perspectives in Cardiology, and was on the editorial board for the Canadian Alzheimer's Disease Review. To learn more about Dr. Lynn, please find more information in the speaker bio section on the left of your screen. So without further ado, I present to you Dr. Lynn.
Thanks very much, Farah, and welcome to all our participants across the country. It's a great honor for me to speak to you. And today what I'm going to do is talk a little bit about the ABCDEs of diabetes management. And what we're going to do is I'm just going to flash ahead here with the slides. Hopefully the slides are moving for you. I thought I'd show this interesting picture of ants. You know, way back during the olden days of the emperors, they used to actually diagnose diabetes by peeing onto rocks. And then what they would do is wait the next day and see if actually the ants would come. And if the ants would come because of the sugar, that means that there was diabetes. So thankfully we've moved quite a bit away from that. Otherwise my office would be full of little piles of rocks for each patient. And so today I'm just going to give you some background and I'm going to come up with the rationale of how come the ABCDEs became so important in diabetes care and in this version of the guidelines which are being used by doctors across the country here in Canada. And actually when I travel internationally, these guidelines are also being used elsewhere. And then hopefully during that time we can talk about how we can all lead healthier lives and manage our diabetes risk better. So first we'd start off with some polling questions. So the first question is, where are you from, so that we get a sense of where people are. So I'm just going to, if you can click on the region that you're logging in from, then we will take a look at the answers. So I'll just give everybody a few minutes or a few seconds to click onto the button. And then we'll go from there. It's nice to see where folks are logging in from with this new technology. Across, let's see if we got the results. Okay, so we've got a good chunk of folks from Ontario, and then we've got a spattering across, and we have a few international folks as well. So welcome to our west side folks, and even Nunavut, as well as international folks as well. The next question is, how old are you? So please check off your age. Don't worry, we won't judge. I'm actually an older fellow, so I think we could all hang together in that way. So please click on your age category, and I'll give you a few seconds. What the survey says. Okay, so we have a majority of people are between 40 and 59, and we have some folks over 80 joining us as well. So thank you all for plugging into this technology. And how are you participating in the webinar? Are you at home, at work, group? And then it lists that out as well. So please just click on which one applies. If you're playing hooky from work, I won't tell your boss, so for joining us. So we see that a good chunk are at work, logging in, so you're learning on behalf of your colleagues. Many people are coming from home as well, and you in the groups. Thank you. And how are you affected by diabetes? And you can check as many as you want on this one. Is it about yourself? Is it type 1, type 2? Is it a family member or your healthcare professional? So check as many that apply to you in terms of how diabetes affects. Okay, so there's a good chunk of folks that are healthcare professionals, so thank you for joining us. We can share some good insight, and you can share some insight with me as well in the question period. And there's many people that want more information on diabetes, many that have type 2 diabetes, and some with type 1, and also some that are at risk that would like to reduce risk. So we'll touch upon some of these areas that might be useful for everybody on this call. But I thought I'd start off with this picture. This is a funny slide that was saying that, you know, Italy has been lending out their statues to make some money because of the economic crisis. So David has been visiting the United States for 2 years on loan. And unfortunately, David now returns to Italy after 2 years being in the U.S., but unfortunately, he looks like this now. And but he has lots of sponsors along the way. So obesity is by far one of the most important things that have happened in our demographics. And what's happened is that, of course, as obesity rates are going up, so is diabetes rates. The two are hand in hand. And as diabetes is going higher, what we're seeing is that the heart attack risk goes up. And later on, kidney failure is also going up. So in other words, diabetes has a far-reaching effect on our healthcare system and on our patients. So that's why it's so important for us to understand diabetes. This is a funny picture, which was, I guess this was a gimmick. But initially, we thought of diabetes as just mainly too much urine. In other words, people are peeing out sugar. So therefore, we thought of it as just a disease where it increases urine. But what we quickly understood was that patients with diabetes and without diabetes are at very high risk. So this is the Framingham group. These are a group of researchers looking after folks in Boston. And what they noticed in their very long study, if you're 50 years old, a man or a woman, without any heart disease yet, if you have no diabetes, your risk as a man is 30% of having a heart attack over your lifetime. But if you had diabetes, it was 67% had a heart attack. For women, you could see no diabetes at 16% chance of a heart attack, but 57% if you have diabetes. So we began to understand that diabetes dramatically increased your risk of having heart attacks. We also knew from our own study here in Ontario, looking at about 1.5 million people, the dotted lines are people that do not have diabetes. The red is men, and the blue is women. So I don't know how we switched the colors around, I guess, to give you a variety of looking at this thing. And the solid lines that you see at the top are people with diabetes. So patients with diabetes, red line being a man and the blue line being a woman, you can see have much higher heart attack risk than people that do not have diabetes in the dotted line. But what's interesting about this graph is the following, is if you are a person that's 70 years old, no diabetes, that's when you first have your heart attack, is around age 70. But if you had diabetes, you would have that very first heart attack at age 50. So it would seem that not only is there more heart attacks with patients with diabetes, but it happens earlier. So think of it as speeding up the process of heart disease. That's what got people very scared in terms of diabetes, in terms of we need to manage it well, because we're having more heart attacks at an earlier stage in life. So if we were to look at all the bad things that happen to patients, let's say down at the bottom you can see stroke and heart attack and ischemic heart disease all the way over to the right, which is limb amputation. What you realize is that if a normal person is in the red line, what is the increased risk of ending up in hospital with these things if you have diabetes? And you can see the graph is quite a bit higher. So you're more likely to have stroke, heart attack, more likely to have kidney disease. So for example, 6 times more likely of having kidney disease and 20 times more likely in terms of amputation. And it's these numbers that made people realize that we must manage all the complications of diabetes very well so that we do not have these horrible events happen to our patients. And I think that's part of the mandate of the diabetes guidelines, to make sure that all physicians and patients are aware of all of the risks, and we try to manage everything that we can reduce these risks for our patients. Now, I must admit, I have to introduce you to a patient of mine. I'll call him Victor, so I don't disclose his real name, but he's 59 years old when I first met him. He had type 2 diabetes, and his family physician was saying he's a bit complicated to look after and couldn't look after him well, so I sort of adopted him when he was looking for medications at the pharmacy to be renewed. And when I got his chart sent over to me, these were all the things that Victor had. We had, bypass. He had all these complications over a 5-year period that were related to diabetes. And that list is sort of hard to look at, so I've decided to sort of reorganize it for you and just talk about each organ that he had. I like this one, George Bush trying to use his head. I'm not sure if that's possible, but anyway. So he had a stroke in 2005 and 2006. What I've done is I've listed all the organs that diabetes might affect on the left-hand side. So you can see the brain, the eye, the heart, the kidneys, and the thing at the bottom is sort of your legs. So in other words, the circulation in your legs. And so let me just take you through Victor and see what's happened to him. So he had his strokes. This is the back of a normal eye. So this is what it looks like in a normal person. The blood vessels there, that's supplying blood to the back of the eye. And in the case of Victor's eyes, you don't need to be a doctor, but you can see that his is quite different. So you can see that there's been a lot of changes and damage from the diabetes. And so therefore, Victor's vision might be clouded. And this is a picture of a patient where there was actually bleeding in the back of the eye because the sugar makes the blood vessels very weak, and sometimes they'll begin to leak. That's why the ophthalmologist plays such an important role in terms of eye examinations. Sometimes they'll play laser tag, where they fire a little laser in there just to seal up an area so that it doesn't bleed in this particular fashion. But in terms of Victor's vision, because his disease is quite far, his vision is more like the right-hand side. So it's a little bit blurry. There's some patchiness areas, some areas that are blocked off, whereas normal vision is what you and I hopefully are seeing right now. So in the case of Victor, his vision was poor because of his diabetes. In terms of his bypass, okay, so this is his surgery. This is what we do in bypass surgery, where we reconnect the piping, I guess, in the heart. We actually had to have bypass because his arteries were clogged up because of his diabetes as well. And in terms of, I like this picture, this is the way you should use the bathroom. So in terms of his kidneys were also affected as the sugar sticks inside there. And so therefore his kidneys were not doing too well either when I met Victor. And finally, this is all your blood vessels in your body. So the sugar, unfortunately, does damage everywhere into the blood vessels. It sticks on the inside of the blood vessel. And so it can cause problems down in the legs, so there might be some blockages down there. And I remember he had a very difficult time walking because his calves would start to hurt because he wasn't getting enough blood flow into his calf muscles. And finally, I hate to show you this picture, but he needed an amputation of his toes because the circulation got so bad that there was no more circulation in the tips of his toes. To save his foot, we actually had to do amputations. These are all the complications that you would see in a very poorly controlled diabetes patient. So let's reorganize his history. So in the large vessel, that's what we mean by macrovascular disease. So the big blood vessel areas, he had his stroke, his heart attacks, and his toes. And in the small blood vessel area, that's what we mean by microvascular disease. He had eye problems, which is retinopathy. EKD means kidney disease, and neuropathy means nerve damage, like he was having numb feet as well. So these are all the complications of diabetes if it's not well controlled. So he has every complication known to man about diabetes. But the good news is that if we control the diabetes and we work hard, then patients do not have to suffer these. So Victor is a situation where, maybe he didn't take his medications properly, or maybe he didn't pay attention as well as he should have. Therefore, he's faced with these complications. But for the vast majority of patients with diabetes these days, we should be able to avoid many of these complications for them. So that's sort of the setup, and the concept is how many percentage of patients do we have diabetes in Canada? And everywhere I go, I tell people it's around 7 or 8%. And I'm just going to show you, this is based on age separation, okay? So going from the very youngest to the very oldest. And what we see is that it's different based on your age. So the dark blue line is women, the light blue line is men, and red is the total. So what you could see here is that if we start looking at people in the 60s to 70 and 80 area, you're actually looking more like 25% of them have diabetes. About 1 in 4 will have diabetes. So you're right. Across the whole country, it might be only 6 or 7%, but then you're including kids as well. If you look at the seniors, they're actually around 25 to 30%. So that's why it's so important for us to make sure that they're well looked after so that they don't get complications like our patient Victor. And this is the diabetes guidelines. It's about 212 pages. This is what doctors and nurses, pharmacists, and other allied healthcare professionals are using to manage diabetes. And it's sort of reviewing what is the best way that we can treat patients. And I'll give you an example of one slide from this area. Is how do we diagnose diabetes? We now have 3 different ways of diagnosing diabetes. And I'll just take you through it quickly just so that we understand what each test is looking for. The FPG stands for fasting sugar. So that's your sugar first thing in the morning. The 2-hour PG is the postprandial glucose. So that means what happens after you eat. So 2 hours after you eat, what happens to your sugar. And the A1C I'll talk about in a second. So we have 3 different ways to actually diagnose people with diabetes. So let me start off with the first one. Okay, this is when you're waking up. And I'm not sure if this morning was like this for you. So the fasting sugar means that you haven't eaten anything all night long. So who's giving you sugar in your body? Because we need sugar to burn as fuel. So it turns out our liver is actually lending sugar all night long so that it's keeping us alive. So therefore our liver is helping us by lending sugar. So if you have a very high fasting sugar, it means that your liver is pushing out too much sugar into your bloodstream. And when I use the word sugar, I really mean glucose, because that's really what's running around in our body as a fuel source. And so all our cells burn that. So your liver is lending out. So if you're fasting sugar, your morning sugar is very high before you eat anything, because the liver is pushing out a little bit too much sugar. And so we have different ways of trying to manage that and different medications. This is the test that you take for the after your meals. So we used to just check after your meals, and sometimes we still do that and see what happens to your sugar after you eat something. But what happens if you eat a big meal or a little meal? So therefore, your doctor may be asking you to drink this specific amount of sugar. You drink this thing, and then 2 hours later, then you get a blood test. And then we can see how your body handles it. And this test is really looking at how does your pancreas deal with a big sugar load. Can it make more insulin in order to get rid of that sugar and move it out of the bloodstream? So this test is like a stress test for your pancreas, kind of figuring out, do you have any capacity to kick it up if you happen to take sugar? So it's measuring a different part of diabetes along the way. And then finally, this is the A1C. So many of you might have heard your doctor saying your A1C is 7% or 8%, something like that. And what this is measuring sugar sticking inside your body. So the way sugar does damage is that it actually sticks to the inside of your blood vessels, to these little proteins. There's little things that hang out. When the sugar sticks to that in your eye and your kidneys and in your heart, that's how it does those damage that we talked about in Victor. So therefore, to measure how much sugar is sticking, we said, can we measure something in the blood that sugar is sticking to? And that'll give us an idea how much sugar is sticking in your eyes and things like that. And so it turns out our hemoglobin, the red stuff that carries oxygen for us, the sugar sticks to that. And so therefore we can measure of all the blood in your body, what percentage has sugar stuck to. That's why we give you back a percentage, so 7%, 8%, that. And that gives us a sense of how much the sugar is doing damage inside your body. So that's a nice number to look at as well. And normal being less than 6%. So if your doctor tells you you're at 8.5%, it means you're quite a bit a ways. And if you have diabetes and we want you under good control, we're usually looking around 7% as being a good number. So normal being 6%, but 7% would be a sign that you have pretty good control of your sugar. So this one is, I show you this slide because I think some people were worried that they're at risk of diabetes. What do we mean by that? Is if your blood tests come back and they're kind of in the gray zone. So for example, if the fasting one, the first morning sugar, if it comes back more than 7, then you have diabetes. If it's below 6, you're normal. But what do we do between 6 and 7? That's sort of a gray zone. That's known as impaired fasting glucose. In other words, you're not perfect, but you're not diabetic. You don't have diabetes yet. The same thing with that after the meal, you know, that 2-hour test. Above 11, if it comes back above 11, then you have diabetes, and below 7.8, you're okay. But what do you do for the people in between at 7.8 and 11? So that would be the impaired people. So these are people that are at risk of having diabetes in the future. And the A1C, that sugar sticking, above 6.5%, you're diabetic, you have diabetes, and then below 6%, you're normal. So again, we have that little gray zone. So these are the zones where we say that you're at risk. You may become a patient with diabetes in the future. And if we were to look at just the A1C one at the bottom, we can actually tell you what your risk is. So let's say your A1C right now is 5%. And if you look on the right-hand column, then your risk of getting diabetes in 5 years is somewhere between 5 to 9%, so very, very low. But let's say your A1C is down at the bottom, let's say 6 to 6.5%. Now your risk of having diabetes in the next 5 years is between 25 and 50%, so that's a fairly high risk. So that's why we could use these numbers to give us guidance as to who is at risk, and then therefore we might work harder for those people at risk. So what can we do for them? I like this slide very much. And it says, I beat anorexia, you know, it's huge. But anyway, so obesity is the one thing that we can try to do. So there was a very nice study that was done. And this study looked at 3,200 men that were overweight, that they were on that borderline. In other words, they didn't have diabetes yet, but they were in that high-risk zone. And they did 2 things to them. They either did nothing, which is that placebo means that they did nothing to them, and about 40% of them developed diabetes over that 4-year period. But look at the bottom line, which is lifestyle. So lifestyle was able to reduce the risk of developing diabetes for these people by almost 60%. And what did they mean by lifestyle? It meant half an hour of exercise every day, 5 days a week. So let's say Monday to Friday, half an hour every day, and a weight reduction of around 10 to 20 pounds. So in other words, if we can do that, if we can reduce our weight, if we can exercise, we can reduce your risk of developing diabetes over the next 4 years by about 60%. So I think that's something very useful for us to remember. So for people at risk, this is what we have to think about, is that we can actually change that risk as we move forward. And if you think about half an hour every day, 5 days a week, it sounds hard, but I think if we slowly started, I think we could do a good job at getting close to that, especially if you're able to prevent diabetes by such a large degree. The other question that people had is that, what happens if we treat everything for a patient with diabetes? I don't want a lot of patients like Victor, because he has too many complications. It's very painful for him to go through all of these complications and to see all these specialists. So a group in Denmark did a study called Steno-2, and they asked a very simple question. If we treat everything really well, in other words, treat the sugar really well, treat the cholesterol well, treat blood pressure well, make sure people quit smoking, make sure that they exercise. If we did everything as best as we could we change what happens to patients like Victor? Or is it just, there's no hope that everybody is going to have problems like this? And so they did this study, and they followed only 160 people. So this wasn't a huge study. And 80 people got usual care, so sort of my normal care, which isn't that great, versus 80 people that got excellent care. They had nurses that were involved that would go and encourage them to take their medication, make sure that they were exercising, make sure that they were following a good diet, and made sure that if they were smoking, that they quit smoking. So they did everything that they could for the patient. And what you see happening to the patients was very interesting. I'm going to show you two lines. The red line are the people that I'm looking after, for example. This is how often they had heart attacks, strokes, or died. That's that line. But if you look at the intensive group, the group where they had a nurse go out there and talk to them, make sure they did all their things, you could see that there was a big reduction. So they didn't have as many heart attacks, strokes, or surgeries. And in fact, it's about a 50% reduction. So half of the events were removed by becoming aggressive in that way. And on the far left, you'll see something called NNT5. That means how many people do we have to treat to protect one person in this way? So if you treated 5 people more aggressively, in other words, made sure they did all the right things, then you would protect one person over that period in terms of having a heart attack, stroke, or dying. So that gave us great hope that just because you have the diagnosis of diabetes, it doesn't mean that you have to go through all these painful things that I listed with Victor. In fact, we can actually prevent many of those things from happening. They also looked at the small blood vessel types of diseases. And so this is a slide looking at what happened to the eyes. Remember, there's eye damage, kidney damage, and the nerve damage. What we could see here is, I hope this will work here, yes. So the intensive group is on the left-hand side, and the non-intensive group, my group of people, is on the right-hand side. So if it's on the left-hand side, it means that the intensive group did better. So the first line, nephropathy, that's about kidneys. So the kidneys were better. The second line, retinopathy, is about eyes. So the eyes got better. And autonomic neuropathy, that's the full stomach. That's where your stomach, the nerves going to your stomach is not working well. And it seems that that gets better as well. The only thing that didn't get better is the numb feet. So if the diabetes patients develop numb feet where they can't feel it very well, unfortunately, even intensive therapy doesn't get that back. And the reason is very simple, is when the high sugars come in, they actually go into the nerve cells and they actually damage the nerve cells. So once you have permanent damage, then it's hard to get back. So that's why we want to control sugars and control everything very early on. So therefore, people do not get numb feet. Because once they get numb feet, we have to give them medications that will help them deal with that numb feet. And these are medications that are not changing the diabetes. They're just allowing people to live well. So that's why we try to avoid that at all costs. And that's why I think earlier treatments and managing disease well early on has so much benefit for our patients down the road. Now, the question is, how well are we doing at all of these things? So the key thing is the following, is how well are we doing in Canada specifically, Canadian doctors treating Canadian patients. So this was a big study, about 5,000 patients. And what they did was they sent out things to doctors and just said, you know what, send us your patients' information with diabetes. How well are we doing? Of course, nobody knew the names or anything of the diabetes patients, but basically we knew what their sugar levels were and how well we were doing. And the question was, are we reaching targets? Because we always set targets. We say, you know, your sugar level should be this much in the form of A1C. Your cholesterol should be this much. So this is what we found. If you look at the A1C, which is the first column, that's the sugar sticking to your blood. So that's sort of the damage. About 50% of our patients were at target. In other words, less than that 7%. And the other 50% were above target. So that means we're good, but we haven't covered everybody. The next column is the cholesterol. So this is the LDL, so that's the bad cholesterol. And you can see that the bad cholesterol, about 57% of the people were at their target of 2.0. So that means another 43% were not at target. The next column, the third column, is blood pressure. So this is the blood pressure less than 130/80. And you can see that only about 1 in 3 patients were reaching that target. So the majority are still not at target for blood pressure. And the most sad column is the last one, which is of all those 3 things, how many patients had all 3 at target? And we can see it's only 13%. So that means about 87% of the patients do not have all 3 of those things to the levels that we want them to. And so we were seeing this that actually shocked us, that we weren't doing a great job. We were working very hard. We were trying very hard, but there seemed to be missing. You know, we couldn't get people there. And so we thought that maybe the best way to do it is to talk about, click through here, is to talk about the ABCDE. In other words, go back to something very basic that we learned in grade school or in kindergarten, I guess it would have been, where we started talking about these are the important things to deal with diabetes. And that's where this ABCDEs came from. And if you were to look at that list, this was the list that it came from. So A is that A1C, the sugar sticking to your blood. We would like to see all our patients around 7% or less. Blood pressure, that's the B part. We want a blood pressure that's less than this 130/80. 130 is when your heart is beating. That's the high pressure. And 80 is when your heart is not beating. That's sort of the resting pressure. So we'd like to see pressures that are less than that so that we can reduce the risk of heart attacks and strokes. The cholesterol, the LDL, that's the bad cholesterol. That's the one that delivers cholesterol to your heart. We would like to see that less than the number 2. And so we had these very clear targets. And D are drugs that are good for your heart. In other words, they've been shown to protect people from heart attacks and strokes. And these are the categories of medication. And aspirin is listed in there as a possible option as well. And then E is for exercise, and we'll put in there eating as well. So in other words, these are the lifestyle things that are very important. And then S became smoking, and more importantly, stopping smoking, so smoking cessation. So this became the ABCDEs of good diabetes care, and that was completely based on that trial that I just showed you, that STENO2 trial, because they showed that if we could do this for all of our diabetes patients, we could remove half of the risk of heart attacks, strokes, surgeries, those kinds of things. So that's really where this list came from, and we would love if all patients knew this list, and we would love if all doctors like myself would practice this list for all of their patients along the way. Now, I'm going to just take you through a few of these bullet points here. Let's just do the sugar business for now and the A1C. This was the sexiest picture they would allow me to put in terms of sugar sticking. So the idea is we used to think about diabetes as eating sugar, but we realized that many things break down into sugar. So your breads is starch, and all starch is a long train of sugar molecules hooked together. So you take glucose molecules and you hook it in a chain, and then you get starch, which is very helpful because your body can break that down slowly and release the glucose. And you're absolutely right. I think you have a whole lecture coming up all about glycemic index, meaning how fast does a sugar enter my body. So if I were to take pure glucose, it would enter immediately because it just gets absorbed. If I take it in the form of a starch, I have to absorb that starch, and slowly I cut off one glucose molecule at a time, so therefore it will come in slower. And so therefore we could see that certain foods take longer time for the sugars to come in, and certain foods the glucose would come in quickly. So you could imagine that your body would have to either deal with a huge flooding in of sugar, or it could deal with it slowly. So obviously, if I could deal with it slowly, that would be better. In terms of the A1C numbers, and you're going to have a beautiful lecture on that glycemic index in the future, so I won't spend time on that. In terms of the sugar control, we talk about this distribution. So this little funny airplane wing or funny bump in the middle is actually saying for most of our patients, we'd like to see that sugar number at 7%. So not more than 7% of your blood has sugar stuck to it. Some patients we might want lower, and for the people that are lower, where we might go after 6.5 patients, are patients that we're trying to protect their eyes, trying to protect their kidneys, these small blood vessels where sugar sticking causes most of the damage. But you'll see at the bottom there's one sentence there that's important. You can be more aggressive with those people, but you must not cause their sugars to go low. In other words, hypoglycemia, because when you make their sugars go low, that will cause problems. So be aggressive with those people, but do not make the sugars go low, because then you can get into trouble that way. Now, for some of our older patients, we let their sugars go higher to 8.5%. And the reason for that is this is a list of patients that we would say, if we control their sugars really tight, will we have any benefit? So if they're very frail, they're in a nursing home, and they're not functioning well, do we have to be so aggressive with them? And the worry there has always been if we get aggressive with them, then we might make their sugars go too low, and then they get into trouble. In the future, if we have ways and therapies that do not cause the low sugar, we may come back and say, look, even for our elders, we should be controlling things to help with their kidneys and their eyes, as long as we're not making them go low. So I think you're going to see us change the tune of this as we move forward. So the whole goal is we want normal sugars if we can, but we don't want to push people too low along the way. In terms of inertia, this is very interesting. They were looking at doctors. When would we start treating people and changing their therapies? And they looked at that percentage of sugar sticking to your blood as a useful tool. And you can see here on the far right, if your A1C is more than 8%, and we know that you want to be at 7%, it takes doctors about a year and a half. That's that 1.6 number. It takes about a year and a half before they actually will make a change to the treatment. If your A1C is between 7.5% and 8%, we would take almost 2 years before we would actually change something. And if it's above 7%, so yours not a target, and between 7 and 7.5%, it would take us about 3 years to actually do something. In other words, I think as a doctor, we often will not make a move for a while. So therefore, I think we have to nudge ourselves a little bit to say, you know, we really want to make that number lower so that sugar is not sticking all over the place and causing damage. So I think we should move a little quicker to make sure that those numbers are corrected earlier on. So this one is a funny picture. This is what I look like at home. You know, so hypoglycemia meaning low sugars. So what is the problem with hypoglycemia? And what is hypoglycemia? So let me just go over this very quickly. So first of all, you develop some symptoms and of low sugar. The sugar levels are usually less than 4. And when you eat something, you get better. So that's when we know that for sure it's probably hypoglycemia. And in terms of the symptoms, there's 2 types. Neurogenic, these are the ones where you get shaky. You might feel your heart beating fast, you're sweaty, you're anxious. In other words, it's like as if you're scared, like you got to go run for your life. That's basically what will happen when your sugars go low. And the other one is where your brain doesn't get sugar. So when your brain doesn't get sugar, you can't think clearly, you get confused, you get drowsy. Now this is more scary because your brain's not getting enough sugar. So we sort of divide those 2 groups up into the symptoms of hypoglycemia. The reason why we care about it is that people that have severe hypoglycemia, marked off in red here, in studies, what happened is that these are people that needed somebody's help when they went low in their sugar. So they actually needed somebody to help them get their sugars higher. They couldn't do it on their own. If you compare those people to people that didn't have that bad hypoglycemia, and you looked at these bad things like heart attacks, strokes, dying, what you notice is that there's about a 2 to 3 times increase in the risk of having those bad things if you have severe hypoglycemia. So I think the takeaway for this is that if you go low, then there is a risk that's higher that you might have some of these bad complications. So some people have said the low sugar causes the complications. That's one way to look at it. Or that people that are very sick and very frail are more likely to get low sugars. So in other words, they were already in bad shape. The low sugar is just a marker of them being very sick. So either way, if you get low sugars, we have to pay attention and we have to figure out why. Is it because you didn't eat? Is it because you took too much medications? I've had some patients that forgot, did they take their medication, so they took another dose of it. And then finally, is it because you didn't exercise or you did exercise a lot and you burned off the sugar? So we try to figure out what exactly happened as to why you went low, and then we correct that problem so that it never happens again. This is a study that came about the elderly. So, you know, if I take normal people, like let's say young folks, and I make their sugars go low on purpose, we can actually cause them to feel those symptoms. And they had a question because some of the elderly, they don't feel their sugars going low. They just sort of pass out. You know, we see them in the emergency department. They passed out. We check their sugar. It's very low, like 2.8, something like that. And we wondered, how come they didn't feel anything along the way? So this study actually took elderly folks, compared them to young people, and they made them go hypo. So the purple area is where they actually made their sugars go very low on purpose. And so what you can see here is that for young folks less than 65, when you make their sugars go low, they all of a sudden feel it. They'll complain. They go, you know what, I'm feeling not good. But in the elderly, you could see it just stays flat. They don't feel anything. So over 65-year-olds, they can't feel the sugars going down until it gets so low that perhaps they pass out. And those are the shaky feelings at the top. And the bottom one is the ones with the brain, where the brain doesn't get enough sugar, where they get confused. And again, you see the young people in the top graph, they feel it. And the people over 65, they don't feel it. So that's why for the elderly, we have to pay special attention to the low sugars. So we must avoid those low sugars because they won't feel it along the way. For your blood pressure, remember we said that 130/80. This is actually a little portable device. Whichever device you use, just make sure you check it with your doctor to make sure that it's reading correctly. So sometimes I'd ask patients, bring it in, we'll check it, you'll check it on your machine, we'll make sure that we're reading roughly the same number, and that way it's a good way to measure yourself at home. And so just remember the number is this 130/80 that we're looking for your blood pressure reading. So if you're above that, we would like to try and get you close to that 130/80. Cholesterol, we must be careful about cholesterol as well, and the number to remember is the bad cholesterol, low density LDL or LDL cholesterol should be less than 2. So if your cholesterol is higher than that, then just ask your doctor about whether you should be doing it. In terms of aspirin, that was interesting. We used to say that all patients with diabetes should take aspirin because they're at higher risk. And when they actually did the studies looking at people that have never had a heart attack or a stroke, should they be taking aspirin to prevent the very first heart attack or stroke? The answer was maybe not. So this is a collection of all the studies, and it looks like the people taking aspirin is on the left-hand side. On the right-hand side, people not taking aspirin. And you can see that the dots are all in the middle. So there's no clear winner here that taking aspirin was useful for people. So that's why now the recommendation is you don't have to take aspirin just because you have diabetes. But of course, if you had a heart attack or stroke, in other words, you've formed a clot, blood clot before, then of course you take aspirin. But to prevent it, we're not really sure. But if you have a very high-risk patient, I would still say aspirin may be helpful, but it's not so clear anymore that all patients with diabetes should be taking it. This is looking at exercise and diet, and I think that you'll have other sessions looking at it better than what I'm going to do with it. But just remember that exercise activity is very important. And at the CDA website, you can actually download the exercise prescription, so how much time and so on and so forth. If you can just remember, we're aiming at about 30 minutes. It says 5 days a week, so 150 minutes total a week. But if you can do it 6-7 days a week, that would be good as well if it becomes part of your routine. Just go very slowly. In other words, I tell people, why don't you walk? A lot of patients will say, okay, I can walk, but how long do I want to walk for? And I'll tell them, why don't you walk for 5 minutes, very slowly, and then we'll walk a little longer. So you stretch it out to 6 minutes, then 7 minutes, 8 minutes. And when you get up to about 20-30 minutes, you're walking quite a distance, then let's just walk it a little bit faster. So walk the same distance in 29 minutes, and 28 minutes, and 27 minutes. And then once you get down to 25 minutes, you're walking quite fast. And what we do is we say, can you walk a little longer? So now you're walking faster, but you're now walking an extra minute longer. So 26, 27, 28, 29, 30 minutes. When you get to 30 minutes, let's walk it a little faster. So that way we can ramp you up very slowly. We won't hurt your heart. We won't hurt your joints. We go very slowly and gently for you. For those that like swimming, swimming is good, but just be careful about the skin in your feet to make sure that everything is dried off properly, because we don't want to get any toe infections or anything like that from the water. So something simple and gentle would be nice for us to increase our activity. I like this picture very much, smoking at birth. So smoking cigarettes is now another list that we have here. And you can see smoking cessation. We put it in there because I think doctors were forgetting to ask patients. We were so focused on the blood pressure and the sugars and everything else, we forgot to explain things to patients about quitting smoking. And you can see here, this is a study that Dr. Youssef from McMaster did, where they looked at heart attacks in relation to cigarettes smoked. So you can see on the far right, if you smoke more than 40 cigarettes, your heart attack risk is 8 times that of somebody that's never smoked. So we can see that any reduction, if you can reduce the cigarette smoking, that's would be very good. And if we can get it to 0, that would be really excellent. You can see down on the far left, it says if you smoke 1 to 5 cigarettes, if you look at that little dot, your risk of heart attacks goes up by 50%, 50. So therefore, you can see that starting doesn't make any sense. Quitting makes a whole lot of sense for our patients with diabetes. This is just a quick note about dementia. As we get older population, they may forget their medications and things like that. So therefore, I think it's useful for us to have pill reminders, simple ways that we can check whether somebody has taken their medication. I think that's useful. One way to check the memory is actually quite quick. You just tell them to remember 3 words, so ball, cat, tree. And then what happens is that after a couple of minutes, you ask them back, can you tell me those 3 words? So that's a quick way to test their sort of short-term memory. But another way to test is making them to draw a clock. So what I do is I ask my patient, this is known as the clock draw test. You tell them, draw me a clock that shows 10 after 11. And so that uses a whole bunch of different parts of your brain to figure out what is a clock, what does 10 after 11 mean, how do I put the numbers, is it the longhand, shorthand, those kinds of things. So I think it's a very good way to do it. This is one of my patients who drew a clock that looked like this. And you could see that this person definitely has issues with his memory and his brain function. And so knowing that, we were able to protect him in the sense that we could manage his medications, and we were able to make sure that he didn't get into trouble because he often would forget whether he took his medication and double up. This is a very funny picture of the definition of a very bad day. So just to remind people that as diabetes might affect the kidneys, a lot of our medications go through our kidneys as well. So as the kidney function goes down, we must remember that some of the medications need adjustment. And this is something that you don't need to remember, but your physician and your pharmacist know very well. And so therefore, as your kidney function goes down and the top is sort of going downward towards the left, there are some medications that we have to stop. The medications are not harmful to the kidneys, but they will build up inside your body. And so therefore, as your kidney function goes down, we just have to make adjustments to the medications that you're taking. So, many people are saying, how do we keep track of all this stuff for diabetes? There's so many moving parts to it. So therefore, the folks at the guidelines at the Canadian Diabetes Association basically came up with a little cheat sheet for us, a little tracking sheet. So this is a little sheet of paper that tracks all the things that we should be monitoring for our patients with diabetes. And now let me see if I can get a zoomed-in shot of it. So you can see at the top it checks off, is it type 1 diabetes, type 2, and then it has risk factors. Do you have high blood pressure, those kinds of things. So it's just a way to keep track of everything that we should keep an eye on. And the middle section is actually, every time you visit, they can put in the blood pressure, the weight, that A1C, the sugar sticking, some notes, and you notice that we now have a column for hypoglycemia, so we actually make sure that doctors are asking about these things as well. And then down at the bottom are important things like, should you go get an eye exam? When was the last time you had an eye exam? Have we had your kidneys checked? So it's a reminder sheet for the patient and for the doctor to make sure that we cover all of those important aspects. And then the back page is good because it just lists the important things for each section. We sort of say, this is what we should do for eye exams, this is what we should do for kidneys, this is what we should do for hypoglycemia, low sugars. So it gives us a sheet of paper that collects all your information together. So if we use that, then we might not miss anything, for example, and we'll make sure that all of those steps that they did in Steno 2 in Denmark, that nice little study, will be done for our patients here as well. These are just close-up shots of those areas as to what we should be looking out for. And so if I were to say the ABCDEs, I think initially people thought we were crazy, but I think it makes sense that it touches upon all the things that need to be done for a patient with diabetes. And the beauty of this is that we think if you do this whole list, then we can get those nice results where we don't have heart attacks, where we don't have strokes. So therefore, I'm hoping that patients like Victor will be something that we hear about. Like in the olden days, we used to have patients that had all these complications. And I'm looking forward towards the future where we take very good care of patients and that patients take very good care of themselves as well. And so therefore, those complications will not happen to the patients of the future. For the guidelines, this is the website. I think you guys might know that already. But if you want to look up any information on diabetes, there's a site there, and maybe we can post up the patient side of things as well. All the doctor information is up on this website. So for all our healthcare providers, all the slides that you see with that nice red logo at the top will actually are available up on the website. and also there's a lot of good tools up there. So if you want to figure out, which patients should get which types of therapies, you can actually look that up, and there's some tools that help you do that. Whether a patient has diabetes based on the blood numbers that you got, there's a little tool to do that as well. So there's many things on the website that's useful. And I'll just conclude with this funny thing. This is the new tax form. Have you seen the new tax form? It says, how much money did you make? And then the next part of it just says, just send it to us. It's so much easier than having to do the tax filling out and things like that. So what I think we're trying to do is make the management of diabetes simpler. So in other words, that ABCDEs now becomes a very simple way that the patients know what they need to do, the doctors know what they need to do, nurses, pharmacists, allied healthcare professionals, we all are working off the same page. So therefore we have the same game plan, and that game plan is pretty solid, that it will reduce all those complications that we talked about. And I'm hoping that in the future, if we all stick with the game plan, that patients like Victor will be something of the past, and hopefully a patient like Victor would lead a good, productive life. Fortunately for Victor, he actually had to take time off work and so on and so forth, so he continues on in terms of seeing all of his specialists. But we're hoping that his case will teach us that we can avoid many of these things with the proper management of our patients with diabetes. And if you are a sufferer of diabetes, that you too can see all the steps that you need to take in order to make sure that you will manage your diabetes well, and that you do not end up with any of them. So on that note, I want to thank everybody for staying awake, and what I'll do is I'll invite Farah back to manage the questions for me.
Thank you so much, Dr. Lin. You have definitely shared with us some amazing information, and there's definitely a lot of learnings to take away, so we just want to send a thank you to that for sure. So as you said, we're going to be going to the question period at the moment. I just wanted to say thank you very much to those folks who have sent in their questions. There's some really great questions, Dr. Lin, and I know, there's not too much time left, but folks, we will try to get everything answered as best as possible. And for those of you whose questions we do not get to today, I do apologize, but please email us at webinars@diabetes.ca, and the CDA will be sure to follow up with you with your questions. So I'm going to just dive in right here. We do have a participant that their question is, I tend to have early morning cramps, and my calf aches when I walk only short distances. Is this another effect, of having diabetes?
Yeah, correct. So a lot of times what happens is when you're walking, you have to send blood into your calves muscles. And let's say you have a little blockage in your calf muscle, the artery that's going down. That's what's happening. It's not enough blood flow going there. It's something we call peripheral arterial disease, or PAD for short, PAD. And it's kind of like, how you hear people having chest pain because there's not enough blood flow going to their heart muscle. You're having the same thing, not enough blood flow going into the calf muscle. So therefore, that's something to bring up with your doctor, saying, I get cramps when I'm walking, and they will check out your legs. But more importantly, we have to give you things that unclog or at least help with that. So therefore, managing the cholesterol, managing the sugar, the diabetes part, managing your blood pressure are the key things for doing that, and quitting smoking. So interestingly, all of those things are the exact same ABCDEs. So the beauty of that list is that it will help with your symptoms in terms of making sure that it's better, and it also helps with the heart risk and the stroke risk as well. So that's why this is a common theme, that if you do all those same things, it'll be better for your legs. But definitely I would take it up with your doctor saying, I have cramps in my legs when I walk. They will check out your circulation going into your legs.
Great. Thanks, Dr. Lin. I'll move on to the next question. This person has stated, how do you alleviate your liver pushing too much sugar through the night, giving a high fasting reading? Should you have a snack before bed? And if so, do you have any examples?
Yeah, so the important thing there is actually what we call insulin resistance. So insulin resistance at your liver means that your liver is basically not listening to insulin. The insulin is saying, look, you don't have to put out this sugar. We're okay. But your liver is continuing on to do that. One thing that drives that is obesity. So when we have a big belly, what happens is that we have a lot of signals moving from the fat itself. So the fat inside your belly, not the one under your skin, the stuff that's inside your belly, sends out a lot of hormone signals. And unfortunately, one of the hormone signals sort of tells the liver, you need to keep putting out sugar. And so what happens is that the liver will then listen to that hormone signal. So one way around it is if we can lose that belly fat. So if we lose that belly fat, the stuff that's inside, then you will not have those signals going towards the liver telling it what to do. One of the drugs that we use for diabetes, metformin, which is sort of the cornerstone of therapy, that one actually helps with reducing the liver pumping out the glucose. That's why a lot of times we'll say that's one of the first drugs that we would put on. But certainly if we can lose the belly fat, then you'll get rid of the signals that are coming from it for your liver to keep making sugar.
Great. Thank you, Dr. Lin, for that response. I'll move on to the next question. Is weight loss mandatory in reducing the risk of diabetes in relation to change in lifestyle, or is meeting the recommended moderate to vigorous physical activity levels important regardless of weight loss?
Yeah, good question. So in other words, is it the weight loss that's doing all the good work, or is it the activity that's doing the good work? So let's say you don't lose weight, will you have zero benefit? So the answer is, even if you don't lose weight, the physical activity is important. Because when you start using your muscles, what happens is that the muscles become more sensitive to insulin. So when insulin comes and knocks on the door and says, please let the sugar come in, if your muscles aren't moving, your muscles are saying, you know what, I don't need glucose. So Mr. Insulin, I don't care how much you knock, I don't need any more glucose because I'm not doing anything. I don't need any fuel. On the other hand, if you move your muscles, your insulin comes knocking and says, here's some glucose, and your muscles are going, good, because I'm burning the sugar. And so therefore, it opens up these channels to allow the glucose to come in. So therefore, by moving your muscles, you will actually make the insulin's job easier in moving that glucose out of the bloodstream and into the muscle. And so therefore, any activity is good. Even if you're tapping your feet while you're sitting on your computer, the muscles are still moving, and therefore you're still inviting the glucose to come in and getting it burnt up and used. So therefore, if you could think of exercises, any exercise is good. You don't even have to run for 30 minutes nowadays. We're saying, like, if you tap your feet, roll your legs around, stretch, those things are all very useful for you. If we can get the weight reduction on top, then of course that is extra bonus. It's kind of like saying, now I'm getting two things. I'm getting, the muscles burning sugar, but at the same time I'm getting rid of that fat that's causing all those weird signals. So if I can get rid of both of them, that'd be fantastic. But definitely exercise alone, even if you don't lose weight, is still very beneficial for you.
Great. Thanks for that response, Dr. Lin. I guess we'll take maybe a few more questions before we end for the day. I'll move on to the next one. One of our participants has stated, I don't have diabetes yet, but I am on metformin. I'm 46 years of age at high risk due to family history. Are there any long-term effects or risks of taking metformin?
Yeah, so metformin has been around for a very long time. One of the early side effects is stomach upset, so cramps, diarrhea. So if you don't have that, then you're not going to have very bad side effects from metformin. Patients have used metformin for a long, long time, 10, 15, 20 years at least. It's one of our original medications, so very safe medication overall. The only time that we worry about it is if your kidneys start to fail. So it doesn't sound like you're in that situation, but then the metformin will build up in your body. So then in that situation, we would like to get rid of the metformin. But in people that have been taking these things, the metformin doesn't do any harm. In your situation, though, if you're trying to prevent diabetes from happening, getting rid of the weight, so remember that study that I showed you, it was exercise and sort of losing the weight. That combination reduced the risk of diabetes by about 60%, whereas the metformin alone arm only reduced it by 30%. So if you're already on metformin, but you're a little heavy or you're not as active, then I would say increase the activity, get rid of that weight, and then that way you'll have the full benefit of preventing the diabetes from.
Great. I'll move on to one of our last few questions. One of our participants has stated, I have PAD and neuropathy, and my question is it necessary to take medication as I really don't care to take medication? Does it keep me from getting worse, help make it better, or does it just make it more bearable?
Yeah, for the neuropathy part of it, the medications that we're giving are just making it bearable. So if you can bear it and without the medication, then by all means, it's just taking away the symptoms. For the PAD part, the blockage in the circulation, that one taking things that lower cholesterol, controlling blood pressure, controlling sugars, that will have an effect on the PAD getting worse. So the neuropathy doesn't fix it, the medications, but if we control your sugars well, then you're not going to get more neuropathy. So that's an important thing. So I think overall, take your medications that are good for the diabetes portion of things, but the ones that are just for the symptom of neuropathy doesn't change the course of disease, just making life more bearable for you.
Okay, great. And our second last question here is about cholesterol. Is it more important to look at the balance between LDL and HDL, or to solely focus on the LDL value?
Yeah, both are important. So the HDL is the cholesterol that is taking away the cholesterol away from your heart, let's say. So think of them as delivery trucks. So the LDL is delivering cholesterol towards your tissues, and the HDL is removing. So for sure, if you have very low HDL, you're not taking it away, it's bad for you as well. For sure, if you have very high delivery, that's bad for you. And the question is, should you be looking at the balance? And the answer is, it's probably the balance. You want to look at a balance of 2 to 1. So 2 delivery trucks for every 1 that's removing is a good ratio. Anything less than that is a good number. So less than 2 is good. Unfortunately, all of the big studies that looked at this only looked at the LDL. So they didn't really say, here's the ratio and here's how you look at it. So that's why we still fixate on LDL. But what we tell all of our students and residents, the young doctors, is you look at LDL, the bad cholesterol delivery, but you always look at the HDL. Is that really low? Because if that's really low, that still gives you increased risk as well. And a couple of things that increases HDL is exercise will increase the good cholesterol, the HDL, and also avoiding a lot of the fried foods will help as well. And so therefore the lifestyle thing seems to make that HDL go up a little bit for you as well. Both make sure your bad cholesterol is down, and we try and bump up your good cholesterol as well.
Okay, great. And for our last question, Dr. Lin, one of our participants has asked, is there a different A1C target for somebody who is on dialysis?
Yeah, so basically any time that we change your how long your red blood cells live in your body, that becomes a problem. Because remember, we're waiting for sugar to stick to the blood. So therefore, people on dialysis, people that have a disease where their blood is breaking down faster, they may not have the right amount of time where sugar is sticking. So the numbers may be falsely raised or lowered. And so basically, if your red blood cells are getting killed earlier, then it doesn't have enough time for the sugars to stick. So let's say you're running at 6, but if I were to let those red blood cells live longer, you might have more sugar sticking to it. Well, I would say that there is a difference, but it's very hard to figure out exactly how much difference there is. But for sure, if let's say you see an A1C of 9%, like way out there, it is not because of the dialysis or because of the blood problems. It is actually the sugar is not treated well. So in those situations, we look at the other ways to control or test for sugar. We look at your fasting glucose. We look at after you eat, how high is the sugar going. So we could use those 2 numbers to tell us how well you are if the A1C becomes unreliable because the red blood cells are dying too early. And so you could use the other 2 tests to monitor and make sure that they're okay as well.
Okay, great. Thanks so much. So that concludes our webinar for today. I'd like to sincerely thank Dr. Peter Lin for speaking on behalf of the Canadian Diabetes Association. It was great to hear all the information you had to share about diabetes and knowing your risks. I just wanted to send a message out, a big thank you to all of those who attended today, and also to all of our wonderful volunteers who have helped coordinate this session. We also do have some more seminars, webinars that are coming up in the next coming weeks. So be sure to check us out at diabetes.ca /webinars to register. And for those of you who would like to know about any sponsorship opportunities, please email us at webinars.ca. We do have a virtual health coaching program that's going to be new to the organization. So for more information on that, please call us at 1-800-BANTING. And if you've enjoyed the webinar and you'd like to make a donation, feel free to visit our website at www.diabetes.ca, or you can also call 1-800-BANTING. We hope you guys have enjoyed this session today, and just a reminder for the questions that we did not get to, please email me directly at webinars@diabetes.ca. Thanks so much, and hope everyone has a great day.